So you're going to check your suction, okay? So we make sure that works, okay? Then what do we do before we suction? Patient's on a vent. Patient's still on a vent, okay? They're on, no, we're going to leave them on the vent. We're going to leave them on the vent to extubate, okay? There's different ways to do it, but this is the way I do it.
Hyperoxygenate.
And the way I do it is right, Prince?
Always.
Always. All right, no way is wrong as long as the outcome is the correct, okay? Just because you come from a different hospital doesn't make it right or wrong. Okay, so we're going to hyperoxygenate. So before you suction your patient, all right, clinically or in your competency, make sure you push your 100% oxygen on the ventilator. How long does that 100% last for?
2 minutes.
2 minutes. So if you hit it, you're high, and let them hyperoxygenate for a few breaths, right? Then we can go ahead and suction. So we're going to suction our patient. Okay, we suctioned out our patient. Secretions are minimal now. I went down twice, maybe, and now I'm going to say, okay, they're clear. All right, so you can kind of talk that out when you're doing it. Secretions, there's not many secretions left. I'm done suctioning. So now what am I going to do? I've suctioned out the airway. Now what am I going to do? I can?
Wait. Suction out the airway.
You test the volumes.
Well, before you
Did Rugi fail?
Huh? Did you fail? You calls VAPS right now. You just calls VAPS. So I suctioned the air. I suctioned the tube, the ET tube. What else do I need to suction?
The mouth.
The back of the mouth. Okay? Because if you let that cuff down, everything that's in the back of the throat, and it's just sitting there, piled there, is going right into the lungs. And maybe they develop pneumonia in a few days because you allowed all that stuff to go down into their lungs. So you're going to suction them out, okay? You're going to suction them out. You don't have to do the leak test for the extubation procedure for competency. I'm not going to make you do the leak test, but you have to know how to do it for clinical. Okay, so I've suctioned out my patient, okay? So that's good. And you always want this nearby because as soon as you extubate them, what are you going to do? You're going to suction them. Okay. So what else do you need nearby? What else do you want to have nearby when you're going to extubate? I got my little guy. Don't worry, we're going to pull that tube out. We're getting that tube out of you.
A bag.
A couple minutes. A bag.
Resuscitator bag.
And mask. I always say both. A bag and mask. Because half the time the masks are not in the bag. They've been thrown away. Okay? And to resuscitate somebody, you have to have a mask. So you always bring your bag and mask with you, even when you transport a patient, bag and mask. All right? Even if they're intubated. Why do I bring a bag and mask if they're intubated when I'm transporting?
So that you can ventilate.
Well, I can ventilate through the ventilator. Why do I need a bag and mask? In case. Always prepare for the worst, so when it happens, you'll be ready. That's my motto. You can call me. Because what will happen, your patient will extubate. Somehow they got their hand free and they're extubating in the hall, and you need a mask and bag. You don't want to do mouth to mouth, right?
No.
So you always want to make sure. The nurse will always say, why do I need a mask? You're on a ventilator. Oh, I'm bringing my mask. Airway's mine, right? I'm bringing my mask and bag. Okay, so we've got a mask and bag. Good. What else do we need to have at the bedside? When you think emergency, what else do we need at the bedside? Emergency. Another ET tube. Perfect. Another ET tube. So you're going to have all that at the bedside ready. The same ET tube. Okay. What else do you need?
Missing makeup and effort.
Stylet. I started to say it. You need a stylet. This is for reintubation. You need another ET tube, a stylet, and what else do you need?
Tape.
Tape or harness. What else do you need?
The
laryngoscope and handle.
Yes.
Okay. What kind of blade do most adults get intubated with? A Macintosh. Curved or straight? Curved. Indirect or direct into the epiglottis?
indirect.
Good. Where does it sit?
Vallecula.
The back of the vallecula. Pulls the vallecula, pulls that epiglottis up indirectly. Good. These are all things you're remembering, right? Good. So we have our laryngoscope and handle. We've got our ET tube. We've got our stylet. We've got our syringe there. We've got our bag, we've got our mask,
Easy
and,
cap.
huh?
You need a easy cap.
You need an easy cap. Thank you. Good. You need all this is at the bedside. Okay? Keep it all in the packaging in case you don't need it. And when you're done and everything's fine, you can put it all back in the code card. Okay, but I'll have it all there because if your patient has severe stridor, you want to be leaving your patient. Do you want to leave him? So I got to go get all the equipment. I'll be right back.
You wait.
No, you don't. You want to be prepared, right? You don't want that to happen to you. Because when emergencies happen, it's stressful enough. Because you're usually by yourself. It's stressful enough. You want to have everything there available so that you can do what you need to do and not have to search. That's the worst, is having to search for stuff. Okay, so bag and mask is there, and I heard a neb. Right? You need a nebulizer at the bedside. Okay? So, why do we need a neb? What drug do we need? And what's the dosage? Albuterol?
Racemic epinephrine.
Racemic epinephrine.
Oh, sorry, Snyder.
Right. So if you extubate your patient, the patient has mild stridor. What's the treatment for mild stridor? What's the first treatment? The first. Do it in order.
Cool mist with
First
oxygen.
is oxygen. Okay. First is oxygen. Then you're going to do cool mist and racemic epi. Okay. I'm thinking of board questions. All right. So you're going to give your neb with oxygen, right? So you're going to give your neb. So you're going to hook your neb up to oxygen. There's your oxygen. You're going to give your racemic epi. What's the other name for racemic epi? Anybody? I played hangman once with that. You want me to play hangman again?
I bet you won.
It begins with the letter V. Nobody?
Vapinephrine.
Yes, vapinephrine. Okay, vapinephrine's the other name, another trade name. But sometimes they say, hey, can you get me some vapinephrine? You need to know what we're talking about. Racemic epi, okay? So racemic epi, now that we have Pyxis and Omnicells for our drugs, you can't just have it at the bedside. When I was a student, if you didn't have racemic at the bedside, you would get...
You were wrong.
You would get sent home. Okay? Because it's that serious. You need to have that racemic nearby. So you have a neb nearby, because you don't want to go searching for a neb. Just bring the neb to the bedside. You have access. You can get a nurse or somebody to grab the racemic, because it's in the Omnicell. Okay? Just make sure it's on the floor, at least, before you extubate your patient. You don't want it to be in pharmacy and you don't have it at the bedside, near where you can get access to it. Okay, so racemic epi, what's the dosage? What's the dosage for racemic?
0.25.
Yeah, same as, it's the exact same as albuterol. Same as albuterol. Okay, so you won't forget. 2.5 milligrams, 0.5 cc's, 0.5 mLs. Same as albuterol. And how does it work?
It's like epinephrine. It constricts the...
Vasoconstricts. It vasoconstricts the upper airway. So the doctor says, well, last time the patient got extubated, they had stridor, so why don't you give racemic epi neb to the patient before we extubate them? Do you give it? Prophylactically, so they don't have stridor?
No.
Why, Prince?
I mean, I don't know why I can't recollect, but you shouldn't. I know you shouldn't.
No. So how does it work? How does racemic epinephrine work? You said it vasodilates.
It increases
But
the
how does
heart
it
rate.
get to the upper airway to vasodilate? Because when you breathe it in without an ET tube, it's going to settle the large particles right in the upper airway. Right? It's going to settle right here. So if you have an ET tube bypassing the upper airway, is it going to help the upper airway?
No.
No. So physicians don't even think about that. They'll just say, give racemic through the ET tube. No, you can't. It's bypassing the upper airway. It will never get to the upper airway, so it won't have any effect. So they have to be extubated before you can give racemic. All nebulization drugs are topically absorbed. Okay, it has to get to the tissue sites to hit the receptors. All right. So, like if you have secretions, you don't want to give an albuterol treatment before you suction that patient, because if you have secretions blocking airways, the med's not going to get distal to those blockages. So you want to make sure that the neb can get to wherever it needs to go topically and be absorbed. All right. So the racemic epi is going to help. So you have mild stridor. We said you're going to give oxygen, you're going to give racemic epi, and you're going to give cool mist. What if you have moderate stridor? What do you do for moderate stridor? So patient's moderate. So mild stridor. How do we assess stridor? Period.
The sound, like
Huh?
how high pitched it is.
Where do you listen for stridor?
You can hear it.
Like you can hear it. It's very
Well,
loud.
you're going to be listening with your stethoscope. If it's bad enough, you can hear it. But if it's mild, you might not hear it.
On trachea.
So you're going to listen over the trachea, right, with your stethoscope. And if it's mild, you might not audibly hear it, but if you hear inspiratory stridor on inspiration, you know, if you can hear it with your stethoscope, that would be like a mild stridor. They still need to be treated if you hear any kind of stridor. So mild, we've done that therapy. What do we do for moderate? Now moderate, you probably can hear audibly. What are you going to do for moderate stridor? Same thing, just add one. So tell me the first three things you're going to do. Oxygen, racemic, cool mist, right? What's the fourth thing you're going to add for moderate? No, you already said racemic epi. Yeah, you're going to add a steroid. Specifically, we give Decadron, okay? We give IV Decadron, okay? So you're going to ask the physician to order Decadron for your patient because they have their stridor is moderate stridor. Decadron takes about how long to be effective? It's a systemic steroid. How long does Decadron take to become effective?
Less than 30 minutes.
Systemic steroid. How long in the ED?
2 weeks.
Right. 3 to 5 hours.
Yep.
4 to 6 hours. It's going to take hours for that to be effective. So in the meantime, how many racemic epis can you give? How many racemic epis can you give right in a row? I know we've talked about that.
Racemic epis are PRNs.
Okay, so your patient's having stridor, so you're giving it to them. They're having stridor.
Like every
You
2
gave
hours,
it to them.
half
There's
an hour to 2 hours. So you can
it's just like a neb. You're going to give it Q3 times 20 minutes for the first hour. Okay, it's just like an albuterol. Your patient's actively having stridor. You're going to give racemic Q3 times
20 minutes for the first.
Q3 times times 20 minutes for 20 every 20 minutes. You're going to give it for the first hour. Okay, and if it's bad enough, you're going to add Decadron to that. And you're also going to get a cool mist. How are you going to set up a cool mist? What do I mean by that? What are you setting up? Wyatt, what are you setting up for a cool mist?
The large volume jet.
Yeah, yeah. And if you said large volume jet to somebody, to a therapist, they would have no idea what you're talking about.
I figured that out with Catherine.
You did?
Yeah,
She should remember from
she
school.
told me cool mist, and I said
She hasn't been
that.
graduated that long. Huh?
Yeah, just she said cool mist, and she asked me what it was on the wall, and I said it was large volume jet nebulizer. She's like, no, and I was like,
That's what she said.
based on what I learned, that's what.
What did she
Like,
say
no,
it was?
it's
She
cool
said
mist.
no.
Oh, it's just cool mist.
All right.
We call it an aerosol. To go set up an aerosol mask. That's what we say. But it is a jet nebulizer, and we have small jet nebulizers, right? And we have large jet nebulizers, the aerosol bottles. But that's just not lingo that's talked in the hospital. She's forgotten it already. That's funny. Catherine graduated. Did she tell you when she graduated? Probably 8 years ago, maybe.